Bismillahirrahmanirrahim. I am Dr. Sayyid Raza Muhyiddin, member of the visiting faculty, Times Institute Multan for MPH classes. And today is the ninth lecture of healthcare systems analysis and health policy and planning. So today we will learn an old story of the devolution plan and healthcare in Pakistan. And as you all know, health is the basic commitment of all the governments, and to be healthy is the basic right of all the human beings. So different governments at different times in Pakistan, they adopted different strategies to provide health care to the people. And as you know, in Pakistan, if you can divide into two eras, the one era is being the country being ruled by the democratic governments, whatever the standard of democracy it was, but the democratic governments elected by the people, and then the dictatorship or martial law and be ruled by the, armed forces. So the health is the subject of the international WHO being the mother and just the overall mentor of the all the health activities in the world. And then is the national health systems, the Federal Ministry of Health. Then there are provincial governments and the local governments. So if you critically analyze in the democratic governments, the health systems were mostly governed by, and the other education and other systems were governed by federal governments and the provincial governments. The local government systems remained poor and ineffective in the democratic era. Because why? Because all the governments, they want to gain more power, and this local government system was entirely different from the provincial and the federal government system. But fortunately, the martial law governments are the so-called dictatorship governments, because at that time the assemblies were not in process or not in the commanding position, they were banned or were nowhere. So they emphasized on the local government system. So health was, then were on the shoulders of to provide health were mainly on the shoulders of the local government system. Ayub Khan introduced basic democracy system. Then the Pervez Musharraf gave the devolution plan, which is the topic of the today. And then there were certain modifications. So during the PPP government in 2008, the health was just transferred, delegated to the provincial governments. So federal government became independent of the health problems of the country. Now coming on all this detail and pretext, coming on the topic, the devolution is when central government transfers power to the local government. This is called devolution. And in response to the failure of federal and provincial levels to provide the amicable and nice health care to the people, the NRB National Reconstruction Bureau formed in the times of Mr. General Pervez Musharraf. They gave a local government system that was called devolution system of 2000 by General Naqvi was the founder. And I've already told you what the meaning of the devolution. And the devolution have got three major forms. There is a decentralization, there is a delegation, and there is devolution. So this devolution or this system is close to the local people because being administered by the local governments, it is close to the people. So the locality, the local people or the community is gets freedom and flexibility to impose its own decisions on the planning side. Now there was at that time there were systems of district nazams. They used to be head of the local government in devolution 2000, and this system remained up to 2010 when the powers of the district nazam were taken away. This post was, the idea was gone, and then the chairman of the municipal or mayor of the municipal corporation and chairman of the district councils, they were introduced, but they were not given this health and education, commandment. So then the district coordination officers, which were established during this 2000 devolution system, they were given the head of the district health authorities. So now we see that what is the devolution plan, and we first you see what is the VN under it. VN is that the health is a basic human right and must be available and acceptable to an affordable framework to all. So to this end, an integrated approach to public health in the district will combine preventive, promotive and curative health at all levels. So reductions in demand of curative care would be translated into improvements in its quality. And then these promoting good governance in health sector by meaningful and consistent emphasis in prompt, equitable and professional service delivery must become a cardinal principle of the department. So this was the VN behind it. Now this devolution, decentralization, bundling is the transfer of authority or disposal of power in public planning, management and decision making from the national level to sub-national levels or provincial levels, and from a higher to lower levels of the government. So this is devolution, as I told you earlier before. So the main objective is to provide the means for community participation and local self-reliance and ensuring the accountability of government officials to the population. And now what are the objectives of devolution of powers? It is empowerment of the people at the grassroots level. Already I told you. And then to make the district the dominant level of decision making in health department. From national to provincial, the district is, all in all to make all the decisions and to improve the quantity and quality of healthcare delivery to the people close to their doorsteps. And then it is also an integrated approach to public health, combining preventive, promotive and curative health at all levels. So in the devolution plan, what were the responsibilities and functions at the district level? These were to prevent and control communicable diseases and non-communicable diseases. Then there was food sanitation, then maintain medical and health statistics under HMIS, I told you in the previous lecture. And then there was the, reproductive health was an important responsibility. Then there was the health and nutrition education. For that purpose, health and nutrition supervisors, and the strategy was also, introduced. And then was the environmental and occupational health, you know, functions. Then it was also to make health policy for the province. This is the responsibilities and functions in devolution plan for at the provincial level. So make health policy for the province, legislate on provincial health issues, drugs control under the Drugs Control Act, monitoring and regulatory functions of medical and paramedical institutions, and health research and related health information gathering. So these were five were the responsibilities and functions were at the provincial level. Then what were the resources and how are the assets distribution for the district? So type A or B DHQ hospitals, type C Tehsil headquarter hospitals, type D civil hospitals, RHCs, DHUs, then the sub health centers, MCH centers, dispensaries. So districts will be encouraged to establish their own nursing, LHW, LHV and paramedical training institutions in due course. So it was decided that the districts will, establish their own nursing, LHV and paramedical training schools which were established. Then what was the progress from the start up to now? The posts in Directorate General of Health Services were redesignated. Then the budgets according to new requirements were given. So all EDOs health at that time called EDOs, now they are COs because the district health authorities have been made. And EDOs and ADHOs, the deputy DHOs they were briefed by the department twice on its approved developmental plans, and then briefing was held both EDOs and DCOs of all districts by health department. So all EDOs were instructed to work as a team with the DCOs at the district level, and all EDOs were asked to develop lists of their assets for distribution. So what was the administrative structure in the devolution plan? There was at the district level, there was a district coordination officer at the head. Then of course there was there was a district NAZM, then the district coordination officer, then the district NAZM post I told you was abolished and the district coordination officer became the head. Then was for the health department was the EDO health. So under the district DCO, there were the EDO health, EDO education, 7, 8 EDOs. And under the EDO was, public health department, there were district headquarter hospitals, basic rural health centers, mother and child health care centers, population welfare hospitals, THQs, etc. Then the executive district officer health had the function that he was supposed to ensure that the business of the department offices placed under his administrative controls carried out in accordance with the relevant laws and rules, and to coordinate and supervise the activities of the relevant offices, and then he has to ensure efficient services delivered by functionaries under his control. So as such, the EDO health was the, like a secretary of now the provincial secretary of the district. So there was a concept of the DHMT, District Health Management Team. So the DHMT was to develop a team approach, share and exchange views, reduce the work of DHOs, optimize utilization of human resources, improve cooperation and collaboration among stakeholders. And the constitution of the DHMT, District Health Management Team, was this EDO Health was the in charge of the DHMT. Then there were other district managers. Then the public health sector care providers, private sector health care providers, community at its elected leaders. Then is the role of DHMT was sharing of experiences and exchanging of views and ideas, taking responsibilities and improving technical efficiency by supporting, assisting, and improve cooperation and collaboration with the government and private health related sectors. So, what were the outcomes of health devolution? In the outcomes, you see these are well defined structures have been developed and resources are allocated. Then there is meaningful partnership at provincial, district, tehsil and community level through the establishment of district health management teams and tehsil health management teams and citizen boards. Then the detailed mapping of resources and services were needed to be developed. Then in planning and implementation of program, a right-based and integrated approach were needed to be developed. So, and meaningful action and capacity building would be required in all levels. Now we see what were the advantages of the devolved system in healthcare. It is the advantage are the administrative and financial powers to district authorities, local bodies, representatives are given. So that is a good news. So the community and public is people are involved in the decision making and even the financial decision making. Then involvement in the devisting the programs relevant to local needs and priorities. So there are certain diseases, certain conditions prevalent in certain regions. So one has to plan accordingly as per their needs and wants. Then the strategies and plans acceptable for the community and matching to their socio-cultural and socio-economic background. Then there are the users' willingness to pay for THC in the public sector services if they received improved care. If you are, getting good care, you can just pay for certain tests or for X-ray or for laboratory test or some other service you provide. And then the districts can recover substantial cost and can retain the income. So the districts can increase their revenue through these improved services. And then if the authority or delegation is transferred to the lower level, you create a sense of ownership. And by strengthening of first level care sector, answering many primary health problems like high IMR, high MMR, and mortality, and can be reduced. Then, what is the criteria for allocating district budgets? This is population size, because the budgets are allocated by the provincial government, so they allocate the budget to the districts for in accordance with the population size, socio-economic development, health infrastructure, then health needs and problems. You just measure the burden of disease and then you allocate the budget. Then performance evaluation based on predetermined indicators, and then there is a combination of all these. You make a formula of allocating the budget on population size, your development, your needs, and of course on the performance. Then what are the challenges and constraints? This political willingness of provincial and district governments to work in the new system is a challenge. Then defining their administrative roles with limits and jurisdiction. If the political people involved in transfer postings or, in the budget utilization, then the thing will go worse. Then is the distribution of financial powers between provincial and district representatives. When the district representatives get more influence in the different health functions of the district government, the provincial level members, they are just they make them sad that they are also the public representatives. They should be given more influence in that. So it is the dependency of districts on provinces for how long, because the the MPAs, the provincial assembly member thinks that these districts are dependent on us, so they influence the district governments. So the district governments have is a capacity, financial and administrative way. This is a limited capacity, and then this resentment against the status quo at the provincial level and fear of losing authority. That's why you can't make new provinces, you can't delegate the powers. That is, you think that you will lose your authority. The center always, think that Takht-e-Lahore thinks that the authority is being lost. So then is the lack of trust and losing the profit. And then is the status of public services commission, medical colleges and tertiary hospitals. They were not decided in this devolution plan. They remained independent under the provincial control. Then there are also the international development targets. The targets are the reduction by one half in the proportion of people living in extreme poverty. 2015, this was the target. Then demonstrated progress towards gender equality and the empowerment of women by elimination of gender disparity in primary and secondary education, and then reduction by 2/3 in the mortality rates for infants and children under age 5, and reduction by 3/4 in maternal mortality. So these were the targets being allotted, which have not been achieved fully. And so this was all about Devolution Plan 2000, and thank you very much.